How should clinicians initiate treatment of patients with severe renal impairment who may not want to be treated with interferon?
It's a terrific question, and in this day and age, there is a very large segment of patients who have kidney failure or renal impairment for whom treatment options in hepatitis C have been really limited because of the absence or lack of high-quality clinical data in this population. Historically, the standard treatment for this group of patients has really involved the old standard of care, interferon, which was administered at somewhat reduced doses from full doses given in non-renal failure patients, coupled with very low doses of ribavirin, which is itself renally cleared and can accumulate in persons with renal impairment and cause a number of significant toxicities, including anemia. So perhaps patients are correctly concerned about going onto one of these interferon-based regimens because of the very high rates of intolerance that patients historically have had to these regimens who have had renal impairment or been on dialysis. Compounding that problem is the fact that response rates for these regimens have been less than those recorded for persons who did not have renal impairment. So collectively, between intolerance, lots of side effects, including anemia, coupled with diminished response rates, we really have been lacking for a viable and successful regimen for these very often needy patients who, in many cases, may have more advanced stages of liver scarring that accompanies their hepatitis C infection. So enter the new wave of medicines that have been recently approved that are now interferon sparing or interferon free. These are now oral combination regimens that can be administered with great success, again, in patients who do not have renal impairment. Do we have data to guide us in this group of patients for these brand new medicines that promise potentially much better rates of tolerability in persons who have renal failure? Well, we have some data, but it has been really limited to date. But what we do understand is that one of the major new approved medications called sofosbuvir, which has been the mainstay of several combination regimens, including combinations with ribavirin and combinations with another medicine called lodipisphere, is itself renally cleared. And so we have not quite established the correct and safe dosing level of this medication. There have been efforts recently to try to address this by studying these combinations in persons with renal impairment. And we've learned that reducing the dose of sofosbuvir to 200 milligrams from its standard 400 milligrams has been associated with diminished rates of sustained response of the virus. So going down to 200 milligrams a day appears not to suffice as being a successful regimen. Interestingly, we've learned quite a bit from what we call a real-world experience that has been reported. So there have been a number of centers across the country that have accumulated their limited experience, but collectively speaking, that has amounted to perhaps more substantial experience, to say, here's what our experience has been taking an approved regimen and using them in our patients, our very needy patients who have renal impairment. So we've seen that the use of sofosbuvir either with ribavirin or with cimipravir, another FDA-approved medicine, which itself is actually dosable safely in renal failure, have been associated at full dose in persons who have been attempted with these regimens who have renal impairment, have been associated with actually very good, in fact, comparable rates of success to those persons who do not have renal failure or impairment. So these data, interestingly, are coming in from literally the grassroots level to inform collectively our own understanding of the safety and success of these regimens. Now, from a safety vantage point, it appears that the vast majority of these patients appear to have tolerated these regimens well. But it should be said that even with this real-world experience having accumulated, Studies are ongoing, specifically, in this case, with higher doses of sofosbuvir in conjunction with some of the medicines I described to you a moment ago, in patients with renal failure at higher doses of sofosbuvir, more standard doses of sofosbuvir. Another exciting, I think, development is actually the impending arrival of other all-oral medicines that are themselves not cleared by the kidney. These would include the medicine grizopavir and the medicine called elbasvir. These are two different classes of medicines that have been combined against hepatitis C and have been shown in non-renal failure patients to have very high rates of success. Because they're not renally clear, they do not theoretically require dose adjustment in persons with renal impairment. So a separate dedicated study has been performed in those patients, and a great deal of excitement has attended the presentation of those data in which 94% of these patients responded to a 12-week regimen of this once-a-day fixed-dose combination of those two medications. These are patients with stage 4 or 5 chronic kidney disease, i.e. patients who have severe renal impairment or who are on dialysis. In fact, 3/4 of this population were themselves requiring dialysis. So this is very exciting news for the person with renal impairment, that there are combinations that exist now that could be used successfully, and moreover, impending, soon-to-be-approved regimens that have robust data associated with success and tolerability. So these are it's very, very exciting times for this group of patients who have traditionally lagged behind their counterparts without renal disease, to see that they too will enjoy, if you will, the benefits of the treatment revolution we've seen in hepatitis C.